Greetings, friend, and welcome. The United States has authorized more than 1,000 AI-enabled medical devices, many in radiology, detecting strokes, cancers, fractures, internal bleeding, eye disease, and other conditions. But an AI that worked when regulators approved it may not behave the same way months or years later. Hospitals replace scanners, update software, change medical practices, treat different populations, and encounter new diseases. When incoming information begins looking different from an AI's training data, it is called data drift. Concept drift happens when the relationship between that data and the outcome itself changes. The machine may continue answering confidently even though the world it learned from has moved. In August 2024, the Advanced Research Projects Agency for Health launched Precise AI. Instead of waiting for doctors to notice something is wrong, the system is designed to continuously monitor, diagnose, and eventually correct medical AI before mistakes become a pattern of harm. But how does one machine know another machine was wrong? If an AI reads an X-ray and says a patient does not have pneumonia, Precise AI can later use medical records, tests, diagnoses, medications, imaging, and clinical reports to construct what ARPA-H calls a surrogate ground truth. If later evidence confirms pneumonia, the original answer can be marked wrong. The patient's continuing medical history becomes the answer key used to grade the machine. Precise AI would compare predictions against those ground truth estimates, detect declining performance, identify the cause, and potentially select or create a better performing model in the background. ARPA-H ultimately wants it to detect at least 90% of specified 5% performance declines, correctly identify the cause at least 90% of the time, and restore performance in at least 80% of addressable cases. The systems being watched are not trivial. ARPA-H's examples include AI that flags collapsed lungs and brain hemorrhages, evaluates breathing tube placement, predicts critical care events, and estimates mortality risk in severely injured patients. We already know medical AI can perform very differently outside the environment where it was developed. In 2021, University of Michigan researchers tested Epic's widely used sepsis model across more than 38,000 hospitalizations. At the evaluated threshold, it missed 67% of patients who developed sepsis while alerting on 18% of hospitalized patients. A newer version performed much better in 2026, but researchers still found significant differences between hospitals. COVID showed how quickly reality can outrun training data. Medical models built before the pandemic deteriorated as patient populations and treatment patterns changed. A 2024 Nature Communications study found something even stranger. The underlying data could shift while normal accuracy measurements remained relatively stable. The AI may look fine today, even while the world underneath it is changing. In June 2026, ARPA-H warned that clinical AI is becoming conversational, multimodal, agentic, and continuously learning. ARPA-H even illustrates a future where machines can tell the doctor when its own judgment should not be trusted. A human doctor can be retrained, investigated, disciplined, challenged, or removed from practice. An AI doctor may quietly change because the hospital around it changed. And the proposed solution is another AI continuously watching it and potentially correcting it automatically. When one machine diagnoses the patient and another machine decides whether the first machine can still be trusted, how much of the medical judgment is actually left with the doctor? Tell me your thoughts in the comments below. This is Micah Sai, and you're watching the Singularity Hub. Subscribe for more.